next presentation, Raoul Vellinet, open surgery versus endovascular procedures.
Right. Hello, everyone. My slides are loading. I appreciate I'm speaking to an audience of people who aren't all vascular surgeons. You're cardiologists, you're interventional radiologists, etc. But I'm a vascular surgeon by trade. I come from Edinburgh, which you may recall was where Harry Potter was written from. And hopefully what I tell you won't be as fictional. Look, my workload with legs is predominantly chronic lymphatic ischemia. Don't really treat claudicants. We have guideline-based treatment, and I think endovascular treatment is great in most cases. I was trained, I've been a consultant for 5 years, I've been trained in open and endovascular techniques, but I work in an institution with 7 vascular surgeons and 7 interventional radiologists. We all work very closely, and I'm very grateful that the interventional radiologists do a lot of the endovascular work for me. I simply do endovascular aneurysmal repairs. I don't do anything in the legs, but I do a lot of open leg work. And we have to ask, why are we revascularizing? We're trying to prevent amputation. And there are debates which I think have gotten quite messy over the last 10, 20, 30 years. There's been debates between endovascular operators and open operators, and I think the net summary of what I want you to all know is I think we need to be able to offer both options based on patient problems. And I think endovascular treatment is great. One of the men who trained me is in the room over there. And I think it's revolutionized our frail patient, our simpler lesions, particularly in the aortoiliac segment, and our patients who do not want open surgery. So I am not saying this is a versus, open versus endo. I say endovascular is great. I think open treatment is great. You've got to pick the right patients for the right cases. And so why do I do open surgery for lower limb ischemia? Bad disease, calcification, hostile anatomy, young patients who have a long life expectancy, failed endo, complex revisional cases, and the common femoral and profunda disease, which I still believe needs to be treated open. And this is just an example of hostile anatomy. This looks like, yes, it would be very amenable to a balloon and wire, but this was actually a ruptured common femoral artery plaque that I think if we'd squeezed with a balloon, we would have sent stuff down the leg. So in the way that I simply performed a common femoral endarterectomy for this, and it worked very nicely in a young man who was fit. He's had a good result. We also talk about the possibilities of failed endovascular treatment, and this chap's interesting because he came back to Scotland from Mongolia, having had an attempt to recanalize an occluded iliac system, and I saw all the pictures because they sent them on a CD, and the wires just wouldn't get through, and he decided to come back, and simply I reverted to crossing him over, and although the profunda is amazing here, there is a long femoropopliteal block. I opted to provide him extra runoff for the crossover, and so I provided him a femoropop bypass as well. And so this is just an example of an endovascular approach that was reasonable to try, but sometimes you need to be able to back up that if it fails. Younger patients, femoropopliteal block, less than 65-year-old man, good vein. Best CLI tells us it's probably the right thing to do, and I did it and it worked. This is a case of endovascular complication. This man was getting an iliac stent with a view to doing a femoropopliteal bypass afterwards to provide him inline flow to the foot for some minor tissue loss. But what happened in the endo theatre was the common femoral became occluded, and my pictures are never great, but there is a clot sitting in the common femoral artery there. And so I took him to theatre and finished the job, and I thrombectomized the common femoral, opened up the profunda, and did a bypass just to give him runoff. And so I think all good endo operators need an open surgeon or someone who can do open surgery around them, if that is not themselves, to provide help. And then this is just to confirm, we do a lot of post-procedural bypass duplexes, and this was triphasic flow, wonderful runoff, great result, tissue loss healed. This is a case of durability, and I appreciate that I'm very bad at reconstructing CTs, and I tried my best, But what this is a man in his 60s with cystic adventitial disease who actually developed rest pain. And what interestingly happened was his cystic adventitial disease occluded. Now, I suspect there are people in the room who might want to consider endovascular treatment for cystic adventitial disease, and I think that's reasonable-ish, but I opted to provide a short bypass from the SFA to the below knee popliteal just to exclude it all, because he was a young man with a vein and I was looking for durability. Time will tell if that's right. And then we still get the situation of failed bypass grafts. This is a man who had a FEM-PT graft with a vein, and initially Duplex picked up some stenoses. We tried to salvage it. We salvaged it once, then it stenosed and then blocked off again. We then find that we had a leg that was critical, and I fully appreciate there's people in the room who are able to provide endovascular treatment of a long femoral popliteal occlusion, but I simply felt that it was involving the trifurcation as well. So we actually did a PTFE to the mid-posterior tibial and used something called a Wolf boot that you may know as a St. Mary's boot. Happy to discuss that if you want clarification, but it worked. And it got us out of trouble in a population of patients who need a result to salvage a leg. And then this is another case, CLTI, long occlusion, hostile anatomy, man with vein, and I simply went to the perineal, which was a better runoff. And interestingly, I thought the popliteal was not a great vessel, but I've got retrograde flow into the popliteal and the anterior tibial, so I accept that. But open surgery is not always great. This is a FEM anterior tibial bypass I did, and I tunnel these laterally, and I won't say who did it. We managed to tunnel the vein graft under the iliotibial band, so that has to go back and be repaired, and that caused a few knock-on problems. Graft's still running, we got away with it, but I think there is a technical demand of open surgery that you need to be doing enough of it to recognise when things go wrong on the ward afterwards or in recovery afterwards, and be able to have the ability to think about where to take things back. And I think the interesting thing about this picture is if you look carefully at the graft, you'll see the graft looking great, but it's compressed under the iliotibial band laterally there, which I found was interesting. And I suppose if you do things long enough, you'll generate every complication. So I'm not coming all the way from Edinburgh to tell you that I'm complication free. I cause complications. And then, this is an interesting one. Another revisional surgery, femoropopliteal bypass that was done in my absence because I was doing another case on a trauma situation. The femoropopliteal bypass went down quite quickly, the forefoot went bad, and I had to harvest vein from the other leg and do a fem anterior tibial bypass. And then the foot looked awful. After a transmetatarsal amputation, I had to put a VAC on it, and it took a good few months to close. And I was told repeatedly that this man was going to lose his leg. And I said, no, we're going to be fine. There's good flow. We've cleaned up the metatarsal twice, the transmetatarsal amputation twice, and he came back to see me in clinic recently. And I was delighted to say he has a foot. So that reinforces that hostile anatomy, redo cases, young patients, I think an open option should be utilised where possible as a wider complement to the rest of your work. Now, just a quick talk about the profunda, because that's the other heading of the talk. The profunda femoris typically, in the olden days, was revascularized by a combination of open aortic surgery, maybe long patches, long aortoiliac endarterectomy, aortobiofemoral bypass, then profundoplasty just to get the profunda flow going. But just taking you to the picture there, we are now stenting the iliac and doing a profundoplasty locally. And I think there is a bunch of patients who have a good enough profunda, because traditional teaching is you need inline flow to the foot, but there are a bunch of patients who have a profunda that's very well developed that acts as an endogenous femoropopliteal bypass. So if you can get inflow restoration, profunda flow, I've actually found that I've salvaged a lot of critical patients by just getting the profunda going. So this is an old woman who was frail. I didn't want to do something big for, but we optimized the iliac and did a long patch onto the profunda femoris, and it worked until the iliac stent failed. And then I had to do a crossover, and then it worked again. But there is a proportion of people who benefit from simply getting the profunda running, and I can't really explain it 100%. And just a few pictures. Now, when I do a profundoplasty, some people are using short patches, but I'm extending my incision on the profunda 3 or 4 or 5 centimeters, dividing the crossing veins, making sure that I'm going from good vessel to good vessel. And I think that helps. And that's maybe, if any of you in here do common femoral work, just remember that. I think making sure you've got a good outflow vessel is probably the most important thing for this operation, as it is for carotid endarterectomy or any other form of endarterectomy. So, I think endovascular treatment is great, but I think you need an open toolkit or someone who can provide you an open toolkit to get you out of trouble if trouble arises, or to give you an option to help your patients if required. And I'll finish by just saying we are hosting the Edinburgh Aortic Summit in June 2025, relatively inexpensive. I'd be delighted to see some of you there. We've got some big speakers coming along. Thank you very much.
Thank you. Any questions, suggestions?
This is the main point that vascular surgeon and endovascular doctors, interventionalists should play together.
Exactly.
In the same game room.
I think parts of the world, parts of the UK have a turf war going on. I think I'm lucky in Edinburgh that we all work very well together. And I also appreciate that I've been trained endovascular, but I think we need to get away from this turf war, endo this or open that, depending on UC. You need to get a balanced opinion from a group of experts for your leg, I think. Same with aortas, same with carotids. Good.
Thank you.